There we go. Okay. Well, good morning, everybody, or afternoon, depending on what part of the country you're joining us from. I wanted to thank you all for participating in our Lunch and Learn series. This is the second of our series for this year. Our next Lunch and Learn will be on June 16th, and I'll tell you more about that in just a second. But for those of you that I don't know, my name is Barb Clark, and I am the Training and Exercise Manager for the Intermountain Center for Disaster Preparedness here in Salt Lake City, Utah. For those of you that are new to our organization, the Intermountain Center for Disaster Preparedness is a training and education center. We not only provide educational opportunities like what you're going to experience here, but we also help create drills and exercises for organizations, as well as do research into the latest in disaster preparedness. And we do help organizations with their disaster plans. As we're embarking on this brave new world, we hope that you find some comfort in hearing how others have dealt with disasters and tragedies and come out on the other side much stronger. So I have a couple of bits of housekeeping for you. Following this presentation, you'll receive a survey from SurveyMonkey. If you could just give us your thoughts and help us to continue to improve our offerings for these Lunch and Learn and other courses that we provide at the ICDP. We'd sure appreciate that. Please make sure that your computer is on mute, and you're welcome to keep your video on if you want, or turn it off if you prefer. Either one is fine. Oh, I'm sorry. I have a hard time multitasking, reading, chat, and, and chatting with you. If you want credit for this class, it's really important that I see your name on your little monitor. So if you have just kind of a nickname or just a partial name, if you could make sure that I get your full name. And in order to do that, just go into the participant button, hover over your name, and if you hover over to the right side, it'll say more. And if you click that, you'll be able to change your name on there. If you don't care about your certification or your credit for the class, don't worry about it, but it is helpful so that we can do it ahead of time as opposed to after the fact. If you want a certificate of completion for this class, please go ahead and email me that request. You should all have my email, but I will put it in the chat here in just a moment as well. Okay. And I mentioned before, if you're watching with a group, please either send it in the chat message or text me the names of the people that are in your group, or at least how many of them are in there, so we can get a count. We pay for a lot of our courses with grant funds, and they want us to keep them apprised of how many people we have participating in our courses. So appreciate you taking care of that for me. All right, I think that's pretty much all the housekeeping that I had. Let's go ahead and get started. I would like to introduce you to our guest today. It's Dr. Eddie Stenehjem. Did I pronounce that correctly, Doc?
Close enough.
Sorry. Is it Stenehjem?
Yep, you got it.
Stenehjem, okay, sorry. Dr. Stenehjem is an associate professor of research at Intermountain Healthcare and Intermountain's medical director of antimicrobial stewardship, overseeing antimicrobial programs across our 24 hospitals and over 200 outpatient clinics throughout Utah, Nevada, and Idaho. Dr. Stenehjem's trained in internal medicine at the University of Colorado and completed his infectious disease fellowship at Emory University in Atlanta. Dr. Stenehjem founded Intermountain's infectious disease telehealth program, which provides real-time infectious disease consultation and antimicrobial stewardship support to 19 small community hospitals. Dr. Stenehjem's leadership and research are focused on improving the quality of infectious disease care delivered to patients with an emphasis on developing, implementing, and measuring methods of improving antimicrobial prescribing practices across the continuum of care. Dr. Stenehjem has served on multiple national committees and has represented Intermountain Healthcare at the United Nations, the CDC, and the White House. Welcome, Dr. Stenehjem.
Thank you, Barb.
Thanks for being here today. Did you want to say anything to people before I start asking you questions?
I think just kind of my role in this, I've been part of the infectious disease leadership group here with Intermountain Healthcare, for the past 9 years. And over the past, 15, 16 months, really since we started learning about the pandemic back in December of 2019, have been part of the ID leadership group that has essentially set the different structure and the different protocols in place to be able to manage COVID across our inpatient, our hospitals, and also in outpatient. And then have been really involved in advocacy efforts in our communities in terms of trying to allow people to have a source of information, an unbiased source of information that they can go to and trust. And we've been, doing that now for the past, 15, 16 months and trying to communicate effectively to our communities. And happy to answer whatever questions you guys have. If I don't know the answer, I'll tell you as much.
Awesome. So folks, we have some questions that some of you submitted ahead of time, and we will also entertain any questions that you would like to put into the chat. If we have time at the end, we can open it up so that you can actually ask your question verbally. But just to get us started, I do have a couple of base questions that we'd like to ask Dr. Stenehjem. So this is a real simple one, and because not everybody is in public health or in the medical field, can you just give us an overview of the difference between a pandemic and an epidemic?
Yeah, so, a pandemic is something that affects us globally, affects us worldwide, has global impact, across, the entire globe. And, initially, this was an epidemic where it was focused in China and some in regional areas that really just impacted those particular countries. And then in March, WHO came out and declared it a pandemic because it started to impact the globe. And what we saw and what was just impressive because of our access to data in this day and age is that we saw this virus quickly transmit all the way across the globe. And we saw it, play out in real time. Many of us followed that Johns Hopkins website that showed where the cases were active, and every day you'd log on, you'd see new red dots popping up in different countries. And it was just a really interesting phenomenon to watch, and how quickly a respiratory virus can spread across the globe and impact all of our all the countries. And this is a consequence of our just incredibly interconnected world, where I can get on a plane and be in Paris in 9 hours, from there to the rest of the world. And we watched it play out in real time, and we watched, the pandemic form.
Crazy how fast it's all spread. All right, so on Monday, the Department of Health sent out a situation report, and they had listed the different variants in that report. There were, according to that one that came out on Monday, there were 308 cases of the UK variant, 4 cases of the Brazilian, and no cases of the South African variant in Utah. However, they did have a new one. It was the B.1.526, which they're calling the New York, which had 1 infection in Utah. Can you explain a little bit about the difference in these variants and why there's so much concern about them now?
Yeah, so let's just go back and define what is a variant. This is a pretty scientific term that is now going to work its way into just regular common conversation and into local media. A variant is a virus that has undergone a mutation, and that's it. And we know that this is what viruses do. If you ask any epidemiologist or an infectious disease physician, are you surprised that the coronavirus has mutated and we have these different variants. Absolutely not. This is what viruses do. Look at HIV, look at influenza. This is just common when you have a virus at high transmission rate, which we do. And so all a variant is a modification of the virus. And that modification can make the virus less fit, meaning it doesn't replicate, it doesn't transmit as well, and it essentially dies out, or it becomes advantageous. And so it's a mutation that potentially is advantageous to the virus, which allows it to transmit easier, cause more severe disease, which allows it to propagate more. And so it all depends on what that mutation is. A virus that mutates really quickly is influenza, for example. And so the reason we get vaccinations for influenza every year is not because that the vaccine efficacy is wearing off. It's because that virus changes so much from year to year that we have to give a new vaccine to provide protection against the new circulating virus. Coronavirus is actually a relatively stable virus in the fact it doesn't mutate as quickly as influenza. And so, it's also not that surprising that we're seeing these mutations because there's so much coronavirus in the world right now. And so when you have high rates of replication of a virus, you're going to have high rates of mutations, and you're going to form these different variants that are beneficial to the virus. And so that's what's happened now. There's really kind of three main variants that we're watching. The B117 is the UK variant. It originally was identified in the UK. This is a variant that's more transmissible, meaning that it takes less virus to transmit the infection. Because of that, it can spread quicker. And it may cause more severe disease. The jury's kind of still out on that, with some mixed messages coming out recently. Then there is the variant in South Africa, the B127 variant, which is a variant that we first saw, and we're seeing that kind of creep around the world a little bit as well. We don't know as much about how impacting that is on the transmission or severity. And then there's the P1 variant in Brazil that has really kind of taken over Brazil. And then we have two or three variants here in the US, the 427 and 429 is the one in California. And then there's the 526 from New York. And so when we think about variants, we have to think, well, what's the consequence of the variants? Here, the variants we have in the US, and particularly the ones we have in Utah, are becoming the dominant strain. And so B117 and then the 427 and 429 variants, they are becoming the dominant strain here in Utah, just like they are in the United States. The good thing, however, is that both of those variants are completely managed by our vaccine. And so our biggest concern is that we have a variant that comes into the US that our vaccine doesn't protect you against. That's our biggest concern. But right now, the 117 and 427, 429, and 526 are all covered by the vaccine. And so it really is, at this point in the US, a race of getting vaccine delivery, getting people protected, versus the B117 variant being spread more quickly. And so we are in a good spot in the fact that we've got high rates of vaccine delivery, and it seems to be that we're getting on top of this here in the US. The reason that this concern is a global concern is the fact that when we see countries with really rapid transmission and high rates of viral transmission, think about India right now, that's a breeding ground for variants and mutations. Those variants, those mutations can end up in our communities overnight. And so it is, a really public health threat to us when we see high rates of transmission in other countries, because those variants can end up here and impacting us. Did I answer your question, Barb?
Yes, quite well, thank you. This question from Dre kind of goes along with it. Can you talk about the advantages and disadvantages with transmission in humid versus arid climates?
Yeah, we're learning a lot more about the subtleties of transmission in this virus. That being said, this virus can transmit in any kind of environment. Look at the transmission we're seeing in India. Look at the transmission we saw in the state of Georgia. I lived in the state of Georgia. I trained in Atlanta. you've never been in a more humid environment than you have in the state of Georgia. And they had really high rates of transmission. Look at what we had in Utah, a relatively arid climate. We had high rates of transmission there as well. And so there likely is subtleties in how humidity affects transmission, how much liquid is in the air. That being said, there's still transmission in all those environments. And it may be subtle, and it's not going to be enough of a difference to really protect people against ongoing transmission of this virus.
Great, thank you. All right. So can you explain the difference in the vaccines and how they work, please?
Yeah. So thinking about a vaccine to begin with, we take a vaccine to really get our body to develop an immune response to part of the virus, or the entire virus, depends on the vaccine platform. And what we're doing is we're essentially giving ourselves immunity to that infection without actually getting infected with it. And so, in the case of coronavirus, we are tricking our bodies into developing an antibody response to what's called the spike protein. So if you look at the virus, the coronavirus, the SARS-CoV-2 virus, on the outside, it's studded with these proteins that are called spike proteins. And that's what our body makes an immune response to. And that immune response is typically through antibodies. And that's something we can test in our blood. There's also another arm of the immune system that's mediated by T cells. And we're not going to talk too much about that right now. But the whole point of a vaccine is for SARS-CoV-2 is to get our bodies to produce an antibody against the spike protein of SARS-CoV-2. That way, if we then get infected with the virus, our body immediately recognizes, hey, that's a spike protein. I've developed antibodies. I'm going to make sure I target that virus and take it out of circulation and not allow me, the host, to get sick. So that's the whole idea of a vaccine against SARS-CoV-2. All the different platforms we have, it's just different mechanisms in which to get our body to make a spike protein, as simple as that. And so we've got 2 vaccines right now that we are actively using in the US. It's the Moderna vaccine and the Pfizer vaccine. Both of those vaccines are what are called mRNA vaccines. This is a relatively new technology that we've used worldwide now. All this is giving the genetic code, a piece of RNA that happens to be in some kind of fatty delivery device, into our cells. Our cells take that up, it reads the genetic material, turns that into a spike protein, and then puts that on the outside of our cells. And then our body reacts to that and says, that's a foreign protein, I'm going to develop an antibody to it. So Pfizer and Moderna is just giving it the blueprint and telling ourselves, hey, make this protein. And the cells make the protein, put it on the outside of the cells, and we develop an antibody response to it. And that's what the platforms of Pfizer and Moderna do. There are different vaccine platforms. And so the other 2 that are probably most recently in the news is the J&J platform, and then also the AstraZeneca platform. Both of those platforms are really, really similar. That is using what's called an adenoviral vector to really deliver that payload of genetic material. So instead of giving RNA in some fatty material, which then gets into our cells, we are giving a bit of a virus, an adenovirus, which is a virus that we've been infected with our entire life. But the virus has been changed in the fact that it can only infect our cells once, and it can't replicate. And so it's an incompetent virus. And so the fact that all it does is that this virus is packaged with DNA of the spike protein. You give the vaccine, that virus then allows that DNA to enter our cells. Our cells say, hey, here's DNA to the spike protein. I'm going to make a protein, put it on the outside of the cells, and you develop an immune response. And so it's just a different mechanism of getting that genetic material into our cells, and then we make that immune response to the spike protein. There's other platforms. Novavax, for example, is kind of a traditional vaccine delivery where we're actually giving the protein, the purified protein that we mix with an adjuvant, which just stimulates an immune response. And then you make an antibody response to the actual protein that you're given. But right now, the platforms we're using is the Pfizer, Moderna, same platform with RNA, and then the AstraZeneca and J&J with the adenoviral vector vaccines. But they're all doing essentially the same thing and making our body develop an immune response to the spike protein.
Great. You know, when the mRNA vaccines first came out, there was a lot of concern that, you know, this was rushed through, but it's my understanding that the mRNA studies were being done for like 15, 20 years in the past, and they're not that new. What's new is that they use them for COVID, not some other virus like Ebola or something.
Yeah, so the mRNA technology has been around for about 10, 15 years, and it's been studied and actually working in cancer therapies as well. And it was very quickly realized that, hey, this is going to be a platform that could very well move quickly in terms of developing a vaccine. And the reason I say move quickly is that all we need to do to develop an RNA vaccine is to get the genetic code of the protein sequence, and then design that in the lab, and then start making the RNA. And so that is actually really quick. We were able to get the genetic code for the SARS-CoV-2 virus in either December or January. That was published out of Wuhan. They took that, they said, hey, spike protein, we know from previous coronavirus research, it's really immunogenic. This needs to be our target. It's on the outside of the cell. This is how it binds, so this should be our target. They took the genetic code for the spike protein, brought it in the lab, was able to sequence it, develop the RNA, and then start vaccine trials within weeks, as opposed to designing a specific adenoviral vector, as opposed to purifying a bunch of protein. The RNA platform is really, really fast. And so they were able to get up and get going first, and that's why you saw them come to market first. The whole vaccine development is just a marvel of science. Like, if you look at the past 18 months and you say, what are you most excited about? What surprised you the most? It, for me, was how quickly we came to market with an effective and safe vaccine. Typically vaccine development takes anywhere between 10 and 20 years and hundreds of millions, if not billions of dollars for a pharmaceutical company to put up to develop a vaccine that is completely at risk in case, if your vaccine doesn't work. And we were able to see these trials get up to speed, get moving, and not skimp on any of the safety endpoints. The reason that these trials move so fast is actually, from our government. Our government's kind of support of Operation Warp Speed that said to our pharmaceutical, private industry, make this happen, and what do you need to do it? And so what happened is that the US government took the financial risk away from the pharmaceutical companies and said, we're going to pre-order 100 million doses of vaccine, regardless if your vaccine works. And so that allowed the pharmaceutical companies to say, okay, we're going to move in parallel, with phase 1 trials, and go immediately to phase 2 trials and immediately to phase 3, and be able to set those up and plan for them, essentially at the same time. But we still maintain those safety checkpoints throughout the entire process. And so we didn't skimp on safety, but what allowed us to do was to have those companies move forward fast without taking the financial risk that they otherwise would have had.
Wondered about that. So how long do the current vaccines in the US appear to be working? Do we have any data on that yet?
So the vaccines that have been approved, let's just stick with Pfizer and Moderna, got approved after they had 2 months worth of data in terms of their efficacy. How well did they prevent SARS-CoV-2 infection? The FDA came out early and said to the manufacturers that, hey, we need at least 2 months of safety data before we're going to allow you to come to us for an emergency use authorization for the vaccine. The reason 2 months was selected was that essentially all adverse events from a vaccine occur within the first 2 months. And so you have to have at least 2 months worth of data to ensure that you're not seeing any vaccine safety signals. And I want to say that again, all of the vaccine side effects that we've seen in the previous history of, whether it be RNA vaccines or purified protein or whatever it might be, occurs in the first 2 months. And so we had to see at least 2 months of efficacy data and also safety profile data before the FDA would grant them emergency use. And so our first look at the data showing that it's 95% effective for those 2 vaccines occurred at 2 months. And that's why they go ahead and give them the approval. About 3 weeks ago, Pfizer just updated the data to say, okay, we got our 2 months worth of data, but we're continuing to follow these patients in these clinical trials for at least 2 years. And they say, okay, now we have 6-month data, and that 6-month data shows it to be just as effective as it was in 2 months. Okay, we anticipate that the effect of these vaccines are going to last, much longer than 6 months, but we just don't have data past 6 months. And so that's going to be something that, all of us in healthcare and research and epidemiology are going to be looking at, is the effectiveness of these vaccines as we move forward in time. Right now, what we can say, minimum, you're going to have at least 6 months of effectiveness, but we anticipate it to be much longer than that. And we'll just have to follow these, the patients in the trial and the folks getting vaccinated to see how long that efficacy lasts. But I suspect it's going to be measured in years, not necessarily in months.
So does some of this have to do with what you explained before, is that the variants, might affect that efficacy as well?
Yes. And so there's a question in here about periodic booster vaccines. So it kind of gets at that, in the fact that the reason you get a booster shot is one of 2 reasons. One is that the effectiveness of the vaccine wanes. Okay, and so you get your initial inoculation and we see that the effect of that vaccine is waning. You give a booster shot and you bump it back up. Think of tetanus, right? We get a tetanus shot every 10 years. And the reason is our immunity wanes every 10 years. We get to 10 years and we boost it back up, and it wanes, we boost it back up. The other reason we get another vaccine is if we see that virus has mutated, where we have to now give essentially a new vaccine to provide immunity to the variant. And so the whole idea of when do we get periodic boosters for SARS-CoV-2 is still in question. We don't know, 1, how long this vaccine lasts, and 2, whether or not we're going to need booster shots or essentially a new vaccine for a new variant. And so we'll be watching that really closely. The pharmaceutical companies have already started making and testing new vaccines against the most common variant, particularly the 351 variant in South Africa. And so we'll have more data on that coming, but it is very possible that we'll have to get boosters shots at certain intervals, just like we could do with influenza, because of either circulating variants or waning immunity.
So can they combine the boosters or the COVID vaccines with the annual influenza? Can those, or would they be 2 different shots that you'd have to get?
Likely, work on that is forthcoming. It all depends on the vaccine platform. Influenza is a purified protein vaccination, whereas Pfizer, Moderna, SARS-CoV-2 vaccination is an RNA vaccination. Those 2 you likely can't combine, but potentially Novavax gets approved, and that's a purified protein. Maybe you can mix that with influenza. Time will tell on that. If I had to look forward, I think in the immediate future, if we're going to be getting seasonal SARS-CoV-2 shots, you'll probably be getting 2 shots, 1 flu and 1 SARS-CoV-2.
I've heard people say that they're going to start looking at getting in line again come fall for another vaccine. Can you speak to that? Maybe quell some fears?
That's a bit premature. We first have to get everybody vaccinated. That's priority number 1, and that would also include children and adolescents. And we don't even know if we're going to need a booster vaccine in the fall. And so at this point, I would not be getting in line for it. And we've got a long ways to go before even considering that. We've got a lot of people who get vaccinated.
Thank you. So how likely is someone who has been vaccinated to be an asymptomatic carrier and affect others?
So the original studies on that key question left us scratching our head saying we don't know. The original studies done by Pfizer, Moderna, and the other ones looked at how effective the vaccine was in preventing symptomatic disease. And so that was their endpoint, was symptomatic COVID-19. And it did very, very good at preventing symptomatic COVID-19. We could say nothing about how well it did against protecting against asymptomatic infection, which could then lead to transmission unknowingly. And so we have new studies that have come out now in the past, about 6 weeks that shows that the vaccine is very effective at preventing asymptomatic infection. And so the best estimates we have right now are between 70 to 90% effective in preventing asymptomatic infection, which is just remarkable. And it's really, really impressive because it shows us that getting a vaccine not only prevents severe illness, but it also prevents transmission. And transmission predominantly from asymptomatic infection, an asymptomatically infected person to somebody who's susceptible. And so we're actually in a very good spot currently in the fact that it, yes, greatly reduces symptomatic disease, but it also greatly reduces asymptomatic infection.
So on the sit rep that came out on Monday from the health department, they talked about breakthrough cases, that there were 210 breakthrough cases from people that have already been vaccinated. So are these variants, reinfections, persistent shedding? I mean, you kind of answered some of that a moment ago, but what do you think causes these breakthrough cases?
Yeah, I mean, keep in mind that the vaccine, is only 95% effective, best case scenario. And let's admit, that's amazing. We originally hoped that we would have a vaccine that was 50% efficacious. And now we've got a vaccine that's 95% efficacious. And so this is more effective beyond our wildest dreams. And so incredible, but it's not 100%. And so we've vaccinated 132 million people across the United States, and that's going to prevent 95% of infections. That still leaves 5%. And so getting the vaccine isn't 100%. And so there will be breakthrough cases regardless of variants. There's going to be breakthrough cases with wild type viruses. And so does it surprise me that we have these breakthrough cases? No, not at all. We're going to have these when we don't have a vaccine that's 100% effective. Could it be due to variants? Sure, it could be. None of the variants that we currently have in the United States at large numbers are resistant to the vaccine, but could it? Yeah, sure. We're certainly targeting vaccine breakthroughs to be sequenced to learn from that. But basically, it's the fact that this vaccine isn't 100% effective, and there's going to be breakthrough cases, period. It's just that it's going to be much, much less. We do know that if you do get infected after the vaccine, that the viral load in your nose is less. You've got less viral burden, probably meaning they can have less viral shedding and transmission. And most likely, even though the data is not out there yet, is that you probably will have less severe disease. But we'll have to wait on that data as it comes out. And then also keep in mind that there's going to be some people that just don't respond to the vaccine. And so people that are receiving cancer chemotherapies, medications for autoimmune diseases that are immunosuppressed, that aren't able to mount an immune response, those people have gotten the vaccine, but very well could still get infected. And so it's not 100%, and we expect to see vaccine breakthroughs.
Great. So there was an article that came out probably about a month ago now that said that Brazil's Amazon had reached herd immunity. Is that true, or do you think that was just wishful thinking? And second part of that question is, can you explain how herd immunity would look in the U.S.?
Yeah, so herd immunity for this virus is a moving target. And, the Amazon rainforest that had these significant outbreaks, certainly didn't have well-defined, serologic surveys to identify how many people were actually infected. And then put on top of that, they have a variant called P1 variant that may be more likely to cause a reinfection. And so I think we have a lot to learn from Brazil and what happened there, and why. But I highly doubt that anybody reached herd immunity in those communities. Herd immunity is a challenging concept. So what herd immunity essentially says is that there's enough people in our community that if a virus were to enter our community, that there's not enough people susceptible to it to further spread. Essentially, it just peters out because there aren't enough susceptible hosts to get infected to then pass on to other people for it to grow. And so if we have herd immunity, that virus comes into our community, infects that one person, but then can't be transmitted to other people because there's not enough susceptible people to allow that ongoing transmission. And so how do we get herd immunity from SARS-CoV-2? Well, you need a couple things. One is that you need the vast majority of the population to be protected. And that means either protected from a previous infection or protected from a vaccine, okay? And herd immunity works when that protection is long-standing. Think about measles. That is the most infectious and one of the most infectious viral pathogens on the earth. And the reason that we have herd immunity for it is that over 85% of our communities have been vaccinated, and that vaccine lasts your lifetime. Okay, that's the way you have herd immunity. But if you get a vaccine that wanes in immunity, let's say wanes in effectiveness in a year, well, then herd immunity will wear off as that vaccine wears off. You only can maintain herd immunity as everybody's getting revaccinated every year if you've got waning effect of the vaccine. Also, we have to think about variants, and herd immunity only works when you have a virus that doesn't mutate and doesn't develop these variants, which then can go on and cause infection on top of a vaccine. And so this idea of herd immunity could be very temporary, and the fact that we all go out and get vaccinated, 80% of us, which we need to. But if we then have a variant that starts to circulate in our communities, we're going to have to get revaccinated against that. If that variant allows escape from the immunization. Or if our immunity wanes over time and we become susceptible, then we're going to have to get revaccinated. And so herd immunity is challenging in respiratory viruses, particularly coronaviruses. Take the common cold, for example. That's a coronavirus. We definitely don't have herd immunity against the common cold coronavirus. We keep getting that over and over again. So time's going to tell on this herd immunity business. We just need to get people vaccinated right now, so we lower the population that's susceptible to this infection right now.
Great, thank you. So what exactly is monoclonal antibody therapy, and does it work on the variants as well?
Yeah, so there's been a lot of talk about monoclonal antibodies. And so when you get a vaccine, I said you develop antibodies against that spike protein. And so that's an active immunization. Your body's actively making those antibodies. Now, what a monoclonal antibody is essentially taking that antibody, purifying it, so it's just the antibody targeted against the spike protein of SARS-CoV-2, and then giving it to somebody. And so that's called passive immunity. Active immunity is where you get vaccinated and you make your own antibodies. Passive immunity is when somebody gives you the actual antibodies that then circulates in your bloodstream and then can identify SARS-CoV-2 if it becomes encountered. So that's the difference, active versus passive. It's the same, essentially the same antibody though that we're using. So monoclonal antibodies have come as a potential treatment option for people that have active SARS-CoV-2 or COVID-19. And essentially what happens is that if somebody gets infected, they have mild to moderate disease, they get a test that's positive, and they're at high risk for decompensating or doing poorly. What I mean by that is getting admitted to the hospital or dying. Those patients, when given a monoclonal antibody cocktail, do better. And the fact that there's an 80% reduction of whether or not they need hospitalizations. And that's going to then obviously lead to decreased death rates. And so does it work? Absolutely it works. It only works though if you get it early in the course. And so If you wait too long, if it's day 9 or 10 of your symptoms and you're now getting severe symptoms, ending up going in the hospital, it's too late. Cat's out of the bag. The monoclonal antibody is not going to work. However, if you get the illness and it's only been 2 or 3 days, that's the time when a monoclonal antibody would actually give you benefit and likely prevent hospitalization. We can alter these monoclonal antibodies. And so right now, there's a number of different products on the market. And what we do is we give 2 different monoclonal antibodies targeting 2 different sites of the spike protein. That combination of monoclonal antibodies does work against our current variants, particularly the B117 and the 427 and 429. And so that is a very effective therapy. And what you'll see kind of as things move on is that you're going to see that people at high risk of this disease will likely get monoclonal antibody as a prevention. And so you can imagine a population of people, cancer patients that don't respond to vaccines, they may get monoclonal antibodies as a preventative measure that may last a couple months. And I think you'll start to see that happening, this fall as more and more data comes in.
Lisa just asked, where do you get the antibodies from for that?
Yeah, so there's a number of different ways. So we can make these synthetically in the lab. Then you can also purify these from people that have been infected. But predominantly, they're going to be made synthetically in labs. We were using convalescent plasma. So there was a whole bunch of studies this summer and into the fall using convalescent plasma, meaning we take the plasma component of somebody's blood, which is essentially the non-cellular component of somebody's blood that have had COVID-19, and then we give it to somebody else. And we know that in that portion of that blood is antibodies against SARS-CoV-2. That didn't work as well as these monoclonal antibodies, which are more targeted against our specific sections of the spike protein.
Thank you. So let's talk about the kids. Why have children been mostly spared from COVID infection?
Great question. Yeah, you certainly don't have a definitive answer for you on that. Children can get severely infected. I don't want to downplay that. Kids, especially adolescents, can get severe COVID-19. It's just at a rate that's lower than adults. And so, kids certainly can get severely infected. Fortunately, they haven't been caught, getting severe disease, because if that were the case, this would be a very different pandemic in terms of how we perceive it. But I don't have a good answer scientifically why kids are spared more so than adults.
I'm going to take us back to the antibodies for just a second, because Christy just asked, are the antibodies coming from plasma donors who recovered from COVID? She said, I ask as a CT doing recovery interviews and asking people if they'd be willing to be plasma donors to help current COVID patients get well faster. But we're only giving plasma to patients in the hospital or people that doctors are seeing in clinic settings with the illness.
Yeah, so what you're getting from people that have been previously infected is what's called convalescent plasma. Convalescent plasma in people that have previously been infected with COVID-19 is still needed. We still use that from time to time in certain patients that we can't give monoclonal antibodies to. And so I would say continue to encourage your patients that have previously been infected with COVID-19 to give plasma, because that plasma can be used in convalescent plasma programs. But that plasma is not being purified and used for monoclonal antibody production, which is what companies like Regeneron is using.
Thank you. Okay, back to the kids. So Primary Children Hospital, and I don't know if this changed, but as of about a month ago, they said that they had seen 0 cases of RSV this year. Do you have any comments on that? Is it our improved, PPE that everybody's wearing and more hand washing, or something else?
Yes to all of that. And I would extend the question to be the fact that we haven't seen influenza this year either. So this has been a very unique year in the fact that we haven't seen any significant influenza in our communities, and we also haven't seen any significant RSV in our communities as well. There's a couple of reasons behind that. One, from an influenza standpoint, one is we had a pretty highly vaccinated population. There's a big push to get people vaccinated for flu before the winter season came. So we had a high rate of vaccination. I don't know the number offhand, but it was definitely a push to get more and more people vaccinated for flu. And so you had a population that was highly protected from severe disease from flu. Two is that, typically the way influenza gets into our community is that it comes from the southern hemisphere into the northern hemisphere in the fall, kind of early winter time period. And that is all mediated by travel. And what we saw this year is that the amount of travel that people were doing was vastly decreased. And we had all these travel restrictions. Nobody was traveling from southern hemisphere to northern hemisphere. And so you had a much less of an entrance of influenza into our communities. And our communities were, one, staying at home more, two, not interacting with lots of different people. And when you did, you were wearing masks and you were focusing on hand hygiene. All those things taken together essentially drove influenza and RSV out. RSV is more of an endemic virus, and we were protected by the fact that our kids weren't going to school. And if they did go to school, they were wearing masks, they were doing hand hygiene, they were well spaced. This is what happens when you decrease that, the amount of contact that you have with people, is that you have decreased transmission of viruses, period. We've learned a ton about it. And so not only were we not getting flu or RSV, but nobody else was getting colds from what seasonal coronaviruses or the others, things. And so it just showed the power of public health interventions in terms of social distancing, hand hygiene, reducing the amount of contacts you had in terms of stopping the spread of a respiratory pathogen. And flu and RSV are great examples. SARS-CoV-2 was able to spread more because we had a susceptible population and it was much more transmissible than flu and RSV. And so we saw that continue to spread. But can you imagine the spread we would have seen if we weren't doing these things? It would have been astronomical.
Yeah. See any lessons learned there that we can take to the future?
Well, I think,
okay,
yeah, it's going to be interesting in terms of what are the lessons we take from a public health standpoint that we learned, especially this past 5 months, into kind of seasonal viral, seasonal viral infections. Some things that are kind of no-brainers for us is that this idea of coming to work when sick has got to change. It used to be that I would think about, well, am I too sick where I'm not going to be functional at work, right? That was my question in my head. Obviously it's different if I was seeing patients, but this idea now has to change in the fact that it's not about us. It's not about the individual. It's about the community we're going to see. And so going to work sick, going to school sick, that's all got to change. And will change because we know how important it is to keep our communities healthy. So I think that's a huge takeaway for us. I do think that there's going to be a potential more emphasis on ventilation, spacing people out, hand hygiene, as we think about schools and the workplace. The other kind of aspect of this is that we learned that adults can work from home. It can. Looks like Barb, you're working in.
Yeah, right here.
We know that adults can work from home, and so if you're sick but you can still work from home. We know you're going to be functional and you're going to protect your coworkers. And so that has got to change for our communities and also our employers.
That's great. Lisa asked early on, what was the biggest surprise for you with this whole thing over the last year?
Lisa was a great question. Always question, Lisa. It was a really hard year for us. We were surprised by a lot of things. Every day we were surprised by this virus in terms of how it can, kill some people and then other people can be totally asymptomatic, how some people can have an acute infection and then be fine, how some people can have a mild infection but then have a long COVID, have these symptoms that go on for months. We were shocked at, all the different organ systems that can be impacted by this infection in the hospital, not just your lungs, but your heart, your brain. we were surprised by all of that. From my perspective, what surprised me the most was the public's response to scientific messaging, in the fact that this became such a political hot button item that there was so much antagonism around public health messages. And, for the first time as a physician and a health advocate, I actually had to be escorted out of some speaking engagements that I was asked to give because I feared for my safety, because I was coming in and telling people that, hey, masks work, that masks reduce transmission and masks, prevent suffering. And I was shocked at how some people responded to that. And I think I was a little more hopeful that we would have kind of all rallied together to face this head on. And I think that was probably the thing that surprised me the most, was just how divisive this became as a talking point.
So surprising. Kathleen has a question along those lines. She said she's heard some discussion about whether or not it's okay to not wear a mask in the community if you've been fully vaccinated.
Yeah, not right now. Right now, the message from us in public health and in the infectious disease community is, regardless if you've been vaccinated or not, wear a mask. One, it sends the right message. There's only been a third of the population in Utah that has been fully vaccinated, a third. And that doesn't even count the children, right? That was a third of the people that are able to get vaccinated, have been vaccinated. And so we need everybody to be on board with this, in the fact that we are still in a situation where we can see increases in cases. Look at Michigan. I mean, Michigan has seen this huge rise in cases, huge numbers of hospitalizations in the setting of vaccination. So we are not out of the woods. And so we still need people to rally together as a community to say, hey, this is for the public good. Even if I've been vaccinated and I know that my chance of having asymptomatic infection is much less, my rate of transmission is going to be much less. We want those people still to mask, especially as they go into grocery stores and places that they can't socially distance. One, to send the message is say, hey, I care about this community. I'm going to do everything I can to protect you and protect myself. And I know that the vaccine isn't 100%. And so at this point, at our current rate of immunization, which is great, we're heading in the right direction, but we're not there yet. Our recommendation is to still wear a mask. A mask is cheap, it's effective, and it's not much of a burden. When I leave my house now, it's my phone, my keys, and my mask. I've got masks littered in my car. And so it's just one of these things that let's just hold on a little bit longer. And we'll get to a point where we're not going to have to wear masks, but we got to get community vaccination numbers up before we're there yet.
Taylor wants to know if you've come up with any good ways of talking to the conspiracy theorists that don't trust the government and the science information and the data that's out there. Any suggestions?
I've been taking now a stance of trying to, learn from them, is to say, tell me about why you believe this. Not dismiss them out of hand, but really try to take a bit to understand where they're coming from and why they're thinking that. And I've found that giving them scientific facts isn't going to solve anything. And they're not in a position where they're going to listen to them. I think our bigger focus needs to be on people that are kind of on the fence. Take vaccine hesitancy, for example. There's going to be those people that are anti-vaxxers that will not get a vaccine because of whatever reason. But there's a much, much larger population of people that are just hesitant to get the vaccine, not quite sure. Those are the people that we need to focus on. The anti-vaxxers is going to be almost impossible to change their mind in this acute time. It's the ones that are hesitant that need our help in terms of helping them become more knowledgeable and more willing to take the vaccine. And that takes time. It takes us approaching them with concern and with caring and learning from them. And then telling stories too about, why I got the vaccine or why it makes a difference. Though that should be our focus, not necessarily the hardcore conspiracists or anti-vaxxers. It's going to be really hard to change their minds.
Great. So the last question that I have is, what's next? I think there's another pandemic around the corner. Could there be something worse than SARS-CoV-2 coming?
So, if you take a look back and you think about, outbreaks, this is the biggest we've dealt with in our lifetime, and the most and impactful. But we've also had quite a few outbreaks in the past 2 decades that we've had to manage: HIV, the original SARS-CoV-1, Zika virus, H5N1 of influenza. And if you look at the time course, we're seeing more and more viral, epidemics in our globe. And so, yeah, there's more to come. And I suspect that we'll continue to see, ongoing epidemics and pandemics. I sure hope that we're much more prepared now that we've been through one. We're definitely, setting up viral surveillance programs across the globe to be, more prepared for the next one. We certainly have new vaccine delivery platforms, which will allow us to react even quicker as new viruses emerge. It's not going to be just viruses, but bacteria. And so think about multi-drug resistant bacteria. It's something that is kind of the hidden pandemic right now, where it doesn't affect as many people, but it has very severe consequences. And so I'm optimistic in the fact that we've learned so much and that we're setting up programs and we're seeing governmental funding. And I just hope that that momentum doesn't go away as SARS-CoV-2 becomes, farther in our rearview mirror. But yeah, we're not going to outwit the viruses or the bacteria. They're always going to be with us. And so we'll continue to have pandemics. And it just kind of shows that the investment in our public health infrastructure is worth it. And I think it also highlights the fact of population health is really important. And in fact, if you look at who has the hardest times with most of these pandemics, it's those that are inherently not as healthy as others. So obesity, heart disease, people that have suffered strokes, kidney disease, those are people that are at the highest risk of bad outcomes once infected. And so, continuing to focus on population health is, going to be critical to us withstanding whatever pandemic we see in the future. So, I'm optimistic for the next few months and year in terms of our response to COVID-19. We know how to manage it. We just got to do it. And we've got vaccines. We've got more effective therapy. We're in a much better spot. And especially in Utah, I'm super optimistic in terms of case counts are down, test positivity's down, hospitalizations are down, deaths are down, vaccinations are up. But we can't let our guard down. We have to stay vigilant and just be cautious about kind of our future and continue to focus on public health measures.
Great, thank you. I have two more questions here. Christy, it looks like, asked if all the hand washing and mask wearing and sanitizers that we've all been using, does this have the potential for weakening our immune system in the long run?
Not in this short period. Not in the fact that we've been doing this for a year and a half. I don't think that's going to have any impact on our immune system whatsoever. If that continued for 10, 15, 20 years, could that have a longstanding impact on our immune system and the way we react to different pathogens? Maybe, but most everybody on this call, I don't see any photos of children, have been exposed to so many different pathogens and so many different proteins that we have an immune system that's incredibly robust. And 1 year of not being constantly bombarded by pathogens is not going to affect one thing. I do wonder about, so I had a son who was born March 21st of last year. It was the week of our earthquake. It was the week of turning positive. It was the week that school shut down and the city shut down. And up until about a month ago, he'd never seen the inside of a grocery store. He'd had seen maybe a total of 10 people his entire life. And I wonder about those kids that kind of have this really limited exposure up front early in their life, could potentially have an impact. I don't know. We'll see. I don't think this is going to last long enough for us to really see any long-term effects, but it's certainly scientifically very interesting to think about.
If that's the case, that it will be gone by next year. We can all start traveling again and interacting in new normal ways. Were there any other questions? I think I covered everybody's questions throughout. We don't see anybody typing on here right now, but Dr. Stenehjem, I really appreciate you coming and sharing your words of wisdom and knowledge, and I think we all learned quite a bit. I know that a lot of folks have gotten a public health lesson throughout this last year that they never would have suspected that they would be getting or even wanting. So I think this, the more we learn, the better prepared we are in the long run. So thank you so much. We really appreciate your time. And there's lots of comments in the chat thanking you. Very informative. Everyone, if you wouldn't mind, please, if you need a certificate of participation, email me and I will get that to you. And please, when you get the Survey Monkey, take a few moments to fill that out and help us continue to make these programs better. So thank you all for participating. Thank you, Doc, for joining us today. And everyone stay safe, wear your mask and get your vaccines if you haven't already done so. So thank you, everyone.
Thanks, Barb.
Okay,
Pleasure to be here.
I appreciate it so much.
Anytime.
Okay.
Bye-bye.
Take care. Bye-bye.